Good afternoon, everybody, and welcome to this session, which is part of the PoCoG scientific meeting. We're really privileged this afternoon to have a panel of speakers on a topic that we thought was very, very relevant and timely around self-care for people working in psycho-oncology. My name is Brian Kelly. I'm the chair of PoCoG, and I'll introduce my panel members shortly. But I firstly want to, as is customary, acknowledge that we're all in different parts of Australia, at least, meeting on the lands of the traditional custodians of those lands, our Aboriginal and Torres Strait Islander people. For me here in Callaghan in Newcastle, it's the Pamelong clan of the Awabakal people, and also pay my respects to their elders past and present and future, and also any Aboriginal and Torres Strait Islander people who are participating in this session today. We're going to be recording the session, so I hope everybody is comfortable with that. The session is a webinar, so in terms of interacting, one of the ways we would do that is through the Q&A function that you can see, I think, at the bottom of your screen. Bonnie Laxton-Blinkhorn from PoCoG is going to be moderating that. There's Bonnie, and keeping track of questions, and it's a sort of session where you may want to raise questions as we go through discussion, and please do, and then Bonnie can let me know, and we can go to those questions, or you might prefer to leave your questions towards the end, and hopefully we'll have time for that, and we'll be able to then cover those then. The structure of this session is very much a discussion. We've got three terrific panelists, and really fortunate to have their time here today. And we've structured this in such a way it'd be more like a conversation. And I'll be taking them through some questions and hearing about their experiences, observations, suggestions around this issue of self-care for those working in psycho-oncology through the COVID pandemic. I'll introduce our speakers because we've got the benefit of local experience here in New South Wales, but also what's, I think, tremendously important is an international perspective from Dr. Maria Die Trill from Madrid in Spain. I'll start off introducing Maria. Maria is the director of a psycho-oncology service. She's a clinical psychologist, and Atrium is the name of the service, I believe, Maria, that you work within, providing psycho-oncology services and care in cancer and palliative care services. Many people will know Maria from her role in the past as president of the International Psycho-Oncology Society, and is now president emeritus, and has been very involved in many aspects of psycho-oncology for many years. I can't do justice to Maria's biography and track record, except to say that Maria remains very active in the International Psycho-Oncology Society as a member of the board and a number of the key committees, has experience in establishing the first psycho-oncology service in Spain, a background in psycho-oncology, in experience in the United States at Memorial Sloan Kettering and the Dana-Farber Cancer Institute. So extensive background in this area, and I think it's enormously valuable for us, given particularly I think especially the international perspective on COVID as a global experience and challenge that we've all faced, to hear about that experience elsewhere and to learn lessons from other people and places. So very much looking forward to Maria's contribution to this session. We also have Dr. Laura Kirsten, who's here with us today, and you'll see Laura on the screen. Laura will also be well known to a number of people in the session. Laura's principal clinical psychologist at Nepean Cancer Centre here in the Western District side of Sydney, is chair of the New South Wales Psychologists in Oncology, and also chair of the Psycho-Oncology group of COSA, as well as being on our scientific advisory committee of PoCoG. So a great contributor and a person with a wealth of experience in psycho-oncology. And Jemma Gilchrist is also someone with extensive experience in psycho-oncology and be well known to people. Jemma is a senior clinical psychologist, works at the Crown Princess Mary Cancer Centre at Westmead, and also in private practice and has, as I said, extensive clinical experience in the field, and we'll also be talking about her work across the state in supporting clinicians through COVID. And we also have on the screen Jo Shaw, who is Executive Officer for PoCoG itself. Jo, myself and Bonnie work as a team amongst the others within the Scientific Advisory Committee and the other management team in PoCoG, and very excited to be able to bring this session to you today. My own background is in, as well as chair of PoCoG, I'm here in Newcastle, and is in psychiatry, working in consultation liaison psychiatry with a particular interest in oncology and palliative care. So thanks everyone for joining. We might just kick it off, and there's just a couple of questions I wanted to start with and go around with our panel. And the first question I want to ask you is to outline your role in psycho-oncology through the COVID pandemic and the work that you've been doing, to set the scene for us all about how you've been engaged in that. I wonder if I might start with you, Maria, from your perspective. You're on mute, Maria, sorry.
Sorry.
That old Zoom challenge we all have.
Yeah, sorry. I was just saying that thank you for inviting me to be here with you today. It really is an honor, and I, despite the time it is for me.
Yes, so thank you so much for that. I should have acknowledged it's early morning for you.
But it's fine, and I'm happy to be here with you. I think my experience here with the work that we've done, or that I've done, has really changed a lot since the initiation of the pandemic. I mean, it's been radically different now than it was a year ago. And I think I would like to start by giving you a piece of data, which is the only piece of data I'm going to give you now, that is, we were initially the country in the world that had the greatest number of infected healthcare workers. So by August of this year, we had over 150,000 healthcare professionals infected in Spain. I don't know what the current number is, but we've had a lot of people infected. And we're a small country, and this is a big number for us. And as I said, initially, we were the ones that had the most infections. And a great part of it was because we had absolutely no resources. I mean, there were no PPEs. People were dressed in just bundled up in garbage bags that they had to bring from home to protect themselves. It was really very, very difficult. So when I got this question, I thought, I can divide it like in three different phases. The initial acute phase of the pandemic, where we really didn't even know what we were dealing with or what was expected. I think there was an issue of expectations also. We expected this to finish early, and still a year from now, or a year and a half almost from then, we're still lacking a lot of information, a lot of knowledge of how this virus works, a lot about vaccination, and of many, even on the psychological impact that this is having on staff and on families and on patients. When we met to prepare for this meeting, so one of you mentioned not long ago that in Australia you thought that you were protected from the virus because you've taken such wonderful measures that fortunately the big number of affected people have come in later, and you have that advantage, if we can call anything in this pandemic an advantage, that at least we know something. You're confronting something that has been dealt with in other countries in different ways, so you can prepare for it a little bit better. Here we didn't have time in Europe to prepare absolutely for anything. So initially it was really a question of survival. I mean, psychological support was very, very difficult, even now, to give to staff, because staff was not open to receiving it. They just needed to survive physically and emotionally the situation. And for us, it was very difficult because, well, the staff all of a sudden had to everybody had to become a palliative care specialist because they had to deal. I mean, a dermatologist was put in the front line maybe because there was no other staff and had to deal with dying patients. So this was very difficult for the staff, not being used to deal with death and dying or with advanced disease or people that were very seriously ill, and all of a sudden being confronted with huge numbers of patients in this situation. So,
Maria, sorry, Maria, can I ask what sort of role did you play with those staff? Can you describe?
It was very difficult. It was an issue of just being there available for very, very practical things. I mean, they didn't ask you to even go and support. First of all, we couldn't even enter some places in the hospital. Second, a lot of us got infected. So at one point, for example, I requested, and I called one hospital where I had a patient, a very advanced ovarian cancer patient, hospitalized with COVID, whose husband died at home just suddenly from COVID. This was at the initially. And I called the hospital, I called the psychiatry service chief to ask for somebody to accompany this woman while we were telling her that her husband was found dead. She didn't even know that he had been ill. And the psychiatrist told me, I can't help you because all of the staff is infected. So I have them either at home or in the hospital sick themselves. So it was very, very difficult because mental health professionals, we didn't receive any training on how to use a PPE, and there weren't any PPEs. And the few equipments that we had were for the medical staff. So our help was through the internet mainly. And it was just helping them in very, very acute situations where they were really at the end of what they could handle. Our role was to provide support on an individual basis. I mean, there were hospitals that set up programs with support groups and stuff, but staff did not attend because it was not a priority for them. So, for example, very practical things like, I don't know, you had to be very creative, you know, telling staff to hang pictures of themselves on their PPEs so that patients could recognize them or could see their faces, see who they were, or asking them to put name tags on their PPEs so that the patients could distinguish their name, because sometimes communication is very difficult with these equipment. Telling them to very simple things, to draw smiles on their masks so that patients could see something else than just a piece of whatever of plastic.
No,
and mobilize. Yeah, we worked a lot through the palliative care units, which had greater access than we did, than mental health professionals did. And they had to be there for the rest of the hospital, really. And we had to, one thing that I did a lot was use our personal contacts to mobilize as many resources as we could. For example, I know the director of one of the big hospitals here, and he was desperate trying to get some respirators and ventilators for patients. So I have friends in the police. So these were the things that helped the staff at that point.
Yeah.
Contacting these people to transport, when we were in lockdown, transport the masks that volunteers made at home to transport them to the hospital. It was very, very specific. And
very, very practical, very practical assistance to begin with. We might come back to hear more about that. And I'll go now to Jemma in terms of describing your role and the things that you've been doing.
Gosh, it's just fascinating to listen to that, because it's like it puts us really into perspective. So my role, I was seeing patients, you know, on through telehealth and so on. But in about when all this sort of started to hit and we weren't sure what was going to happen in about sort of April or May in 2020, a couple of organisations just took the active decision to have someone there and ready to debrief and support their staff. So I sort of very swiftly went into a role at Westmead and also with the McGrath Foundation, which is a breast cancer support foundation here, Maria. And so I was lucky because we sort of already had sort of formal meetings set up, so every fortnight. And really in that phase, you know, we were lucky, not an awful lot happened. But later on, of course, when we were into sort of, you know, June this year, it was quite a bit of a different picture. And but lots of the same, obviously to a lesser extent, but lots of the same concerns. So I was talking a lot with really the medical and nursing staff, and they were getting distressed, particularly by, as you say, people being out of their comfort zones. You know, a lot of these are junior doctors, and so they might have done one term of respiratory and a neuro, and then they're just getting used to oncology, and then whoop, they're in the COVID ward. And so they haven't really found their feet, and there's a lot of, and then normally the sort of pecking order they would rely on. So they're, you know, if they're a resident, for example, they might rely on the consultants. Well, the consultants that were brought in were new to COVID as well. So they felt like it was sort of the blind leading the blind, a lot of anxiety around that. And, but it was the simple things. And one of the most stressful things that our staff talked about was the visiting restrictions, which they understood. But it was desperately sad. So they would be all PPD'd up. They can't hug people. They can't touch people. We did the same, writing their names on things, writing their names on their mask. Hi, I'm Jenny or whatever. But they felt that there was a complete disconnect. And probably the most stressful thing, particularly because I do a lot of stuff in Western Sydney, and a huge variety of different ethnicities there. And so very different ways of coping with the restrictions that were put on by the hospital. And so the staff found it really hard to, you know, on the one hand, there would be strict rules and they would try and adhere to them, but other times, you know, other people had let families round the rules. And so the staff felt as if they'd been these constant referees, and when they're trying to provide medical care, it was more like a social intervention. So they found that stuff really hard, actually, just navigating language barriers. And trying to, so a lot of these, that was in the sort of COVID wards, but in the other wards where, say, palliative care, where they were restricting visitors, and you sort of had to try and, you know, there was sort of, you could come in with X number of visitors if someone was in so many hours of their life. And so, you know, who knows that stuff? And so people that would put in those restrictions didn't necessarily understand palliative care. And so all that was probably the most difficult thing. And in terms of helping them, look, it was difficult because none of us have done this before either. So we're trying to think practically on our feet all the time about how to help. And a lot of it was actually just allowing them to debrief, talk about it, normalize it, and actually allow them to have an emotion. Because I think with a lot of the junior doctors, they were all trying to stick a bow on it and pretend they're all fine and nothing bothers them and they're not stressed. And they were very stressed. And these are young people with sometimes little children at home, sometimes elderly, you know, not even elderly parents, but so a lot of stress about it's okay to feel, you know, not a discussion about it's okay to feel stressed, it's okay to feel frightened about passing the illness on, and because I think they felt quite embarrassed.
Well, Jemma, I might come back to that as well, because we want to spend a bit of time about what was helpful and what sort of strategies you used in your role around those sorts of issues. So that's certainly an area we want to explore as we go on. I might move on to Laura now to describe the work that you've been doing, Laura, and then we can go back to looking at what are some of the things that were helpful in dealing with in your role as a psycho-oncologist supporting staff.
So I guess my role is I maintain my work in clinical work in psycho-oncology, but noticed that there was more demands for support from staff, you know, and listen to medical staff making decisions about modifying protocols. There was a lot of anxiety watching what was happening in Europe at the time, because obviously there were decisions being made about who gets, you know, ventilation and who doesn't and things like that. So that just sort of, you know, goes against all the grain of being a helping professional. So we'll watch in that. And then I have more an administrative role where I'm the chair of the New South Wales Health Psychology Advisory Network. So I was feeding into New South Wales and was Health and was a contact person for New South Wales Health about psychology matters. So setting up, you know, what role will psychology have in ICUs with COVID, and looking at ways to set up new services to try and make sure that we're getting people to avoid hospitals, to try and, so, you know, putting in new allied health staff, for example, to avoid, to so we had hospital avoidance or early discharge plans. And then more recently, we're setting up a psychosocial response team to support people who are COVID positive but isolating at home. So we did that sort of at an administrative level, but I had the privilege of actually providing some of the clinical care around that as well, to support those people who are at home isolating and working in some of the outskirts of Western Sydney. We have some, very varied levels of literacy. So I remember speaking to one lady and she not knowing how to use a digital thermometer, never seen one before, that sort of thing. So just getting down to the basics. So I think they were sort of the main roles I've had in this time.
Thank you. So we started to hear more about the sort of impact on the staff you were working with. Are there any other observations in that regard about the sorts of issues as a psycho-oncologist you might have faced with the staff you're supporting? Then we might talk about the sort of issues for the psycho-oncology staff themselves and their self-care. But for the staff that you're working with, the issues around contagion, the impact on closeness with patients, the sort of issues that were coming up for patients, the tragedy of some of the experiences you were describing, Maria, with the unexpected death of family members in circumstances that none of us have ever faced before, and the practical challenges of equipment, resources, uncertainty. Any other particular areas that you wanted to emphasise?
Yeah, I think that one thing that was very difficult here was for the staff to have to take decisions, very difficult, complex decisions that were against their value system, that were imposed because of the government rules or because of their superiors, and these things are coming up now. They weren't. Right. Okay. Because there wasn't any room for them to.
Oh, that's interesting. Yes.
Be dealt with at that point. So the stress that accompanied all these issues is coming out now, and helping them deal with their own personal experience with COVID, because more than one of them have had family members that have died, and they have had to deal with them as physicians or as nurses. And then we also are dealing now with a lot of people that are on medical leave because of depression, some early retirement. I know of one suicide in a staff member, I think they're not very psychologically minded for themselves. Okay, so they don't really. It's kind of embarrassing for them. They've been exposed enough. Their vulnerability has been already very exposed during this pandemic, and I think that for them, what I interpret from their behavior is that for them, receiving psychological support is a sign of weakness. So I find that doing our work online, and if possible, outside of office hours or of working hours, is less threatening to them and is easier for them.
That's a really interesting observation, and particularly, as you say, when the practical tasks of getting through all of this have changed, that then you're seeing the emergence of these issues, the impact, the consequences, the sequelae. Bonnie tells me there's a question that's come through. Bonnie, would you like to?
This is from Amy Pern. She says something that she's found particularly stressful, despite the relatively minimal clinical impact in Western Australia, is dealing as a healthcare provider with people in the community, including friends, and the rampant distrust of government and the health system, conspiracy theories, anti-vaccination, and how much energy it takes to do what I see as an important role in educating, informing, and advocating. It's exhausting, she says. Is this more or less apparent in more acute settings, or is it just one of the many straws breaking the healthcare camel's back?
Very interesting question. Thank you, Amy. And I might ask for a response from our panel thinking about this in terms of issues that you might face as a clinician dealing with COVID, that broader set of concerns about COVID's impact on the perception of the health system, and also the sorts of, as we know, sort of the social psychology of vaccination, if we could call it that. Who'd like to take that question?
I'll say something about that. Actually,
Yes.
I totally agree. I think that's been one of the most stressful things. And when I talk to other psychologists in this that are doing the clinical work, I think partly as well because we're seeing people with cancer, and we're seeing a sort of a physically vulnerable population. We've got the issues to do with them not wanting to vaccine or being vaccine hesitant or whatever, but also the layers around their family and their sort of. So I think it's for a lot of people, it's a lot of distress around way people behaved in the community, the selfishness of. So when we went through the protests and some of those things and the lower rates and etc., then there was I think it was very a dividing idea. So remembering that sort of in Christmas 2019-20, we'd gone through the bushfires and that was a very unifying thing. And then suddenly you've got a group where everybody's, sort of out for themselves. And I think for a lot of people that the world felt quite unsafe. And for us as clinicians, look, I think that was one of the most difficult things for me personally to deal with, just endless conversations about supporting vaccination and understanding the science of it, and I think we were all got a bit of burnout about that. Just empathizing with that, it was not easy.
No, and Laura, you have anything to add to that from your experience?
Yeah, I think I got sent some of the links and went down the rabbit hole of YouTube to sort of see what were people looking at and what was, convincing them. And I could see on a surface level why someone who perhaps doesn't have a good understanding of some of the science behind it would get caught up. So I got that. But I mean, one of the things, the biggest impacts that we had is that we've lost quite a few staff members in New South Wales Health who had chosen not to get vaccination, and we've got a vaccine mandate in New South Wales Health for staff. So I can talk about the psychology workforce that I manage, and we lost about, it's not much, 0.5%, but that's still quite a lot of our staff that we lost in a time when it's difficult to recruit staff. So that's been an impact for us.
Yeah, so there's an interesting issue there about hearing about managing this within our patients, and as you were saying, Jemma, patients with cancer that we normally work with in psycho-oncology and their families, but also health professionals and their own reactions to this. What was your experience, Maria, in Europe?
Well, I think that regarding vaccines, right now, there's, for example, a total lack of understanding of especially healthcare professionals that do not want to get the vaccine. Not as much, the general population, but it's healthcare professionals. I think that part of I thought of this about the perception of everything in a lot. And I think that one of the things that we have lacked here is our images of what was going on inside the hospitals. I mean, all we got were numbers of and a lot of conflicting reports of what was happening, of what we were dealing with, and a lot of confusion from the government, basically. And there was people that couldn't see images of what was happening, really. We only had one image that was very impacting, that was a lot of bodies. They had to use one of the big skating rinks that we have in Madrid, and they were all piled up on the ice. And that was the only very impacting image that people saw. And so I think that people were not really, and still are, many are not aware of the extent of how aggressive this virus is, unless they've lived it through themselves or through somebody close. And there's still a lot of people that don't, and that's very difficult for me. It's been very difficult to deal with, because you are listening to all these terrible stories from healthcare staff and suffering, and it makes, we have groups of clinical psychologists, and we've been talking a lot among us, and it's made us very angry because you really don't know how to deal with this. It's very difficult on top of everything else.
That's a good point at which to ask, well, how do you deal with these sorts of pressures? What are some of the things that have helped in dealing with the pressures on you personally, as well as sort of managing some of those professional issues?
For me, personally, it's been very difficult because when I had three major losses in 1 year, my father and two very close uncles. And at the same time as my father was in the hospital dying, I was sick with my son at home and my sister. So it wasn't easy. Right. And on top, you had all your patients that you also wanted to help. I mean, because you were at home and you were feeling lousy most part of the time, but there were also times when you felt you could do something or you needed to do something. So because of the technology, you were able to hook up with them and maybe do a session or two with a patient or with a family member or with a staff member. But I think that what really has been very, very helpful has been having I am very lucky because I have a huge network of support around me. I have a huge family, and we had just the WhatsApp, we were on chats all day. And when, we have some that live close, some that live in other parts of Spain and stuff, but we were all connected all the time. And then I have a huge support, support from friends. I have a lot of friends. I'm very lucky in that respect. And you get a different view from that side. I mean, you get the friends view, not the family view, and not the professional view of your colleagues. So it was refreshing. It was very refreshing to just, listen to some jokes that people made and stuff. But having support for me has been really the key thing. It has been the most important thing. I think that all of this has made us, or has made all of us working more aware of spiritual and existential issues. People, we have all become more vulnerable, and sharing that vulnerability, I think, with people that you didn't even think you would share these things, also has helped. And just feeling that you were instrumental and efficient in doing your work and in helping in any way you could. I mean, it didn't matter whether it was just cooking for your neighbor or, helping a healthcare staff with some other issue. But just the feeling of being instrumental and efficient and just trying to do your best, I think was very important for me. But also, and I think that this has worked for me as well as for staff, is this being, having some kind of spiritual support. I think that for me has been very important. And in talking with healthcare staff, well, it happens, when you see dying patients too, those who have some kind of support from their beliefs, whatever they are, and die more at peace. And I think this has been an evidence during this.
No, thank you so much for that, Maria. And as you say, sharing sometimes things that you may not have otherwise shared, and appreciate you sharing what I guess it's hard for us to imagine how complex and difficult and that experience would have been. And I'm sure I speak for others in expressing our sorrow for the losses that you've experienced over that time. And the point you make about the importance of the support as supporters of others, the importance of being able to think about not just support in general, but the different types of support. I think it's a really interesting point you make about family, friends, and colleagues doing different things, but also the supporting others even in practical ways, the sense that gives you something you feel you're able to do, and the role of a sense of meaning in spirituality that helps sustain you through things. They're all, I think, enormously powerful messages that you're giving us. So thank you for giving that very personal account. It's much appreciated.
Yeah.
I wonder, Jemma and Laura, your own reflections of what helps sustain or manage and cope.
Oh, it's very humbling listening to you, Maria, actually talking about that. And it's one of the, it sort of resonates because one of the things that struck me when there's lots of talk, you know, on the TV or whatever about, you know, reach out and are you okay day and, you know, use your mental health care plans and absolutely fantastic. But then there's almost like a complete forgetfulness that there's us at the other end of that. And so it's like, so the staff are coming to us support, everyone's coming to us support, our friends, people around us. And so we're supposed to pull a rabbit out of a hat and feel calm all the time. And that's hard because it doesn't happen in a vacuum. You're going through your own stuff. And, you know, we've got our own families and our own things to deal with. And, you know, lots of people, and myself included, had, you know, kids sitting the HSC or, you know, other kids that needed a homeschool or some other fiasco that, you know, was going on. And in the big scheme of things, yeah, it's all doable, but it still has an impact, doesn't it? When and look, things for me that I found helped, I guess, professionally, was to take those opportunities. Like telehealth was amazing for me because I'm someone that used to have to commute for an hour each way to get to the clinic. And now I have to roll out of bed and, you know, put some sort of reasonable top on, and there we are, you know, and that was wonderful. So that meant that I could exercise, and it meant that I wasn't stressing out about getting home and cooking dinner, and things like that were actually good. And holding on to some of those things going forward, I'm going to do. And I think it's been marvelous how all sorts of workplaces have been forced to be flexible, including public health, actually, which I think has been incredible because there's no way they would have let us do this sort of stuff before, I think. And that's been amazing. And I just want to take those opportunities, I think. And just personally, it's been good to, I don't know, to do the connections are important. The far too many Zoom drinks for my liking, well, not for my liking, but probably for my health. Doing things like online wine and evenings, I was having a great time. So things like that helped. Exercise helps, and talking with your colleague, like all our mates, you know, who are in the same boat. Well, maybe not in the same boat, but in the same storm, as that sort of cliche goes. I think that's helped for me.
Yeah, thank you. And I know we've got a question to come to, but I might, before we do that, Laura, whether you have any observations that you'd like to add to this discussion about.
Yeah, I think one of the things it is very sobering hearing Maria's experiences, because I think unfortunately I only know one person who's ended up having COVID in this whole time. So that's quite amazing to hear what's happened over there. But I think what has really helped for me is there's been like just an increased sense of collaboration and communication. I know that's meant that I've had about 4 meetings about COVID a week, which has taken up a lot of time. But in that same process, there's been a lot of sharing of resources, which has been really, really helpful. So we're not having to reinvent the wheel each time there's a new service coming on board or things like that. A lot of checking in with by colleagues, which has been really nice. I get a text message from Brisbane or something like that saying, how are you going, and things like that, which has been really lovely. And I think that's kind of the thing that I'm taken away from this, is because we had a suicide of a senior psychologist that was, you know, a relatively close colleague for us in the past few months. And so we've, as the chair of the Psychology Advisory Network, I'm just being a bit more mindful about, you know, trying to just be a bit more given the space for people to share more openly their experiences and how they're going, and feeling it's okay to not be okay. And I think we just all have this mentality that we just need to soldier on and, you know, get through it. But, you know, it's fine if you're not doing okay, and to have a meltdown or to, you know, have a debrief or a cry or whatever it is. So that's kind of what I'm taking away from it.
Sorry, I'm doing the mute thing now. It highlights, I guess, the uniqueness of this sort of situation that we've all been in different ways, where it's not only what our patients and colleagues are dealing with, but we deal with it personally in our home, with our family, the impact of a pandemic, the fear it might create, the way it's impacted the way we manage our lives, all those things. It's everyone's in it together, and it means different things in different ways. So that, I mean, that's, yeah, it's presents a challenge that we've not faced in this way before. Now, we have a question. I think, Harry, you have a question.
All right.
would you like to ask the question? Yeah.
Sure. So thanks, Brian, and thanks for a fantastic introduction. And again, it's very sobering to hear the different experiences and how that has played out around the world. And I guess my question is really related to this idea that the pandemic's an opportunity for us to reassess and really think about how we want to interact. And I've heard this phrase of looking for a gentler, kinder way of life as we kind of emerge from that. And I would just be interested in everyone's opinions on how we might actually achieve that, both personally and professionally.
Great question, Harry. What have we learned and what will we take from all of this? So over to our panel.
I find I'm hugging people a lot more when I see them. I'm like, I hope this is okay, but we just need to hug. I haven't seen you for a long time. So yeah, I just make sure someone's there so I don't breach HR protocols or anything like that. But I think that, I think for sure that we need to just be kind. And I think, you know, what this has shown us is that we don't need a lot of forms filled out to do things. So I think we need to sort of try and take that on board and roll with it and just work out a way. How do we, especially in health where it's such a big organisation and it can be very rigid, how do we try and make it a bit more flexible so we have we are able to care for our staff a bit better and support them to do, you know, have that nice mix of you know, working from home if possible and within the hospital system on site when needed as well.
I just wanted to add to that actually, because in a structural way and particularly in the private work I do, Medicare items allowing us to do telehealth has revolutionized my life and access for their patients, access to care, you know, the flexibility we've got, the family flexibility. I now see people all over the country. And that was never something that happened before. And I shudder to think if we're not allowed to continue to do that, because that's going to be so hard, I think, for us all to readapt to, just personally as well as professionally. And things like, you know, the way you feel as a clinician doing end-of-life care to palliative care patients who now can see us, whereas before if they were moved off to PCUs where we know we don't have visiting rights or we're not at that hospital or whatever, we lose contact, that's it, done. So we can't see the people at the end of their life and say goodbye and do that work, and things like that have been massively different, I think. And I so hope like some of those opportunities we can keep.
Yeah, no, that's very helpful observations. Thank you. And Maria?
I think that one of the things that we've learned is that we become more aware of that we're all vulnerable and that we need each other, and that we need a lot more mental health resources than we have, and that we need a lot more palliative care resources than we have, and that we need to train people, staff, healthcare staff, and give them like basic survival kits, you know, basic knowledge and tools on palliative care and basic tools on the psychological care of patients and families. I think that this is crucial, and I hope that something comes out of this in this line, you know, more resources in place.
Yeah, I'm reminded of a phrase I think that was used in the UK about post-COVID going back to better, so that we lift ourselves in many ways as a result of this experience, which is a sort of analogous to how we try to work with patients, I guess, and their families, is to see what can be learned from the awful experiences that people might go through. And as you're saying, Jemma, innovation, both Laura and Jemma, innovation in the way we deliver care, the way our systems operate, has you think of what was able to be done almost overnight.
Yeah.
That was quite extraordinary. But then also what it means for us in psycho-oncology. I mean, we've found here, Maria, a much greater focus on mental health. There's been talk about the mental health pandemic that may follow COVID, and new services and resources being developed. And I guess, as you're saying, one hopes that this brings into focus something that in psycho-oncology we've been aware of, that there's a great deal of unmet need for psychosocial support, psychological care of people going through serious illness. And perhaps this has brought that to the fore, but also the needs of healthcare professionals. We've seen them in the spotlight. They were the heroes sort of stories, but also recognizing that they're human. And have needs and impacts of this. So hopefully that's something that makes us much more sensitive to those issues as we recover from this. Yes, Maria.
Can I just add something? And I think it's made healthcare staff in general more aware of the need of what grief work is, because they've gone through so much grieving processes throughout this pandemic that they're more aware of the importance of this work that needs to be done when one is grieving, themselves or their patients or their families or whoever it is. But I think I think the worst is yet to come regarding mental health. I'm absolutely sure of it. We're starting to see the tip of it here now, but I think the worst is yet to come.
It's one of the things that we hear now.
Yeah.
People saying is it's taught us a lot about how, as humans, we are social beings, and so when we're cut off from each other, it has such an impact. And I've even noticed in the hospital I work in here that recognition that when we isolate patients, they can't have visitors and they're going through all of this alone. It's highlighted to people just how important, and we took that for granted, that was part of what helped people through their hospitalisation and their illness. So it's really highlighted some of those very basic messages.
Can I just make a comment on that, actually, from the work I've done with the McGrath Foundation and the nurses, in that they've really found that things like people not being able to attend initial investigations and biopsies and so on, pre-diagnosis, it's had this, there's a big now throughput of that and increased trauma about the diagnostic process and how it affected people, and all those things we normally do as, healthcare workers to encourage people to cope, and those points were all taken away. And so now, months later, we're seeing the impact of that.
Yeah, that's another part of it, isn't it, that we're hearing about, is the care that wasn't provided during COVID.
It was restricted, and then the trauma of that.
The catch up. Yeah. I'm aware that we've got about 10 minutes left. I might, before we go to the last question I want to ask you, well, I wonder if there are any other questions anyone else on the webinar would like to add, or even a comment or an observation that anyone might have. Please feel free. But if not, I might just ask, we've had a terrific wide-ranging discussions. What would be your recommendation around any resources or particular sorts of support you'd recommend? I guess at the end of a discussion like this, where we've covered a range of issues, some of them, may be distressing for people involved in the webinar, or that might have triggered some thoughts about things that they'd like to be able to do. Suggestions about resources or strategies and so on that you'd recommend or suggest to people working in psycho-oncology to cope with all of this.
One of the things I'd say is I think it's good to do the reality check of it's a bit like Instagram, I suppose. Just because people look like that on Insta does not mean that that's what's going on in real life. And just because we look like it's all fine and we can do this and no one's affected, and it doesn't mean that. And so I think sometimes you can look at the others and think, oh, I'm depressed, I'm fed up, I need to talk, I better not tell people I've been struggling. But actually, as we found today, everybody's struggling in their own way. It's been difficult for everybody. And I think that's a valuable thing for us as psychologists, psychiatrists, whoever's listening, healthcare workers, to be able to say it's not been easy, and to be able to share not only the personal stuff, but the professional stuff, and not make it all about the patients all the time. Not that that's not really important, but that's our default. Is it's we're okay. Everyone else should go first. And I think it's all right for us, as Laura said, not to be okay, and to acknowledge that and to share it. I think online there's lots of look after your exercise, look after your health. Although a lot of that stuff's very generic online. There's lots of stuff to read, which is great. And we'll find, but I think sharing it is important.
Yeah, one of the things that brings to mind is some of the structures in order to do that can be helpful to think about. Supervision is one, of course.
Yeah.
mentorship, or going to your general practitioner if you're not sure whether what you're feeling is what others around you might be feeling.
And EAP, which we often don't, we've all got EAP, but do psychologists access it? I don't know, but I suspect not.
What's your experience in that? EAP is Employee Assistance Program.
Yeah, Employee Assistance Programs, which I guess we all have as employees if we're in employed places, but I don't know how many psychologists take them up, actually. It makes me think I've never really asked, but
yes, sometimes there's even greater reluctance among us, those of us working in mental health, to seek care than there is among any other group.
There is, yeah.
Laura, what's your impression about formal structures that people can, or systems that people might use, in addition of obviously to all the other informal supports and others we've been discussing?
Yeah, I really think that, that, as you were saying, the supervision, I think the way that people use supervision, though, people need to think about. So I do quite a lot of supervision in my role, and some people are just very much about, I saw this case and this was what had happened and this is how it happened. Whereas I tend to use supervision more, and Jemma would know this because I do supervision with Jemma, is like, and I felt this, and this is what happened, and then I did this. And so it's really an opportunity for me to sort of talk openly about how I felt about that situation and how I reflected on my own performance and what I could have done better, but also, what it triggered in me. So I think the way we use supervision, for those people who have supervision as available, people, need to think about how they make use of that relationship and try and develop that relationship with their supervisors.
Yeah, Maria, from your experience, the sort of structures that you found helpful, you've obviously been working, you referred to a group of psychologists that come together.
Yeah, but very informally. It wasn't like we had a formal meetings. We had chats, or we had moments where, when can you talk with me, and we made some room or some space for us to get together over maybe with a glass of wine or with a cup of coffee. That was very helpful, and it was also very helpful to share the interventions that we tried to do with our patients and with the staff. And I don't know, I remember, for example, sharing one case that I had, where I felt, this is a patient of mine that I've seen for a long time, and she's an advanced colorectal cancer patient, and her mom died during last year with COVID, and she is one of 4 or 5 siblings. They're all spread out around Spain, and they couldn't say goodbye to their mom, and they couldn't get together either, one of many people in families like this. And so I asked them to pick an object that was associated to their mom, and get together through the internet and celebrate a memorial through the internet, with talking about each one, that picture, that photograph, or that object that they took, just sharing this kind of interventions that we did with our patients. What didn't occur to one occurred to, if you didn't think of something, somebody else thought of doing it. So you got ideas and you were able to share your ideas. I think that was very helpful for us. Sharing the how do you do this, or how can you survive, or what do you do? And what is it that you do? And what do you do when you have 5 friends in the hospital, 10 colleagues that are very sick, and family members also, and how do you deal with all that at the same time? So just having somebody outside there to be able.
Yes, and not become isolated. And
that's crucial.
And it reminds me also the way in which this has distorted for all of us our experience of, in different ways, when there's been loss, the things that we know help through bereavement have been taken away. Being able to share, get together, have the rituals, and then thinking creatively about how to replace that. There's an interesting question that's been posed from Harry. Supervision is part of psychology and psychiatry practice. If you're in a profession which doesn't have this practice, how would you find someone to work with you in this way?
Can you repeat that, please? Sorry.
Yes, given that supervision is so much a part of psychology and psychiatry practice, for other disciplines or professional groups who don't have that tradition, how would they go about finding that? Someone to work with them in that sort of way?
I think you just have to make yourself visible. That's part of our work, and that's been part of our work is teaching, healthcare staff what we can do and how and in which ways we can help them. It's not only showing them, or teaching them communication skills, which they have needed very much here, but it's also supporting them in different ways and letting them know. I think it's very important to let them know that we are available for whenever they need us. And just, being available to them is helpful to them.
Yeah, thank you. Any other suggestions, Jemma or Laura?
Sorry, Jemma.
Oh, I think, most of whatever healthcare profession, I think there's usually someone that you're working with that you really trust and you gravitate towards, and that, that person can be invaluable. And I know, certainly the nurses do that a lot. And work, just someone that you can be open with and work with who's, sensible, and you've got similar value shares or whatever about work. I think that's something that you can do. And so, sorry, Laura.
Thank you. Laura?
I was just going to say, I think that, we've got quite a lovely psycho-oncology community in Australia, and I think tapping into that would be a great way to get some of that support. There are people around, there are opportunities to meet with people, to get to know people, and using the PoCoG or the COSA Psycho-oncology group, or just your professional networks to reach out and connect with people. And I'm sure everyone's nice that I know, so I'm sure people will be open to that. Yeah,
very willing to help. And it's interesting, in the chat we've had an example of sharing experiences, as well as you were saying, Maria, with Amy making a suggestion about what those in genetic counselling. The comment is, we've just instigated a listing of available supervisors, and they're working to develop an online peer supervision group to make it more accessible. And which is a good point to finish, an example of that sort of exchange of support, information and ideas. An online peer supervision can be a great way to do that, to overcome that isolation. I'm very conscious of the time, and I know it's Friday afternoon for everybody, and we tried to pick this time because we thought it might be when you kind of can pause a bit, reflect, and then, rather than going back to work, go off and enjoy the weekend. So and for Maria, it's your Friday morning, so hopefully the rest of the day is okay for you. But thank you everyone so much. The last point I'd make is, don't forget that, as health practitioners, we also need our GPs as well. And remembering that, one of the best pieces of advice we give out a lot of our students is, have your own GP. You're entitled to be a patient and get the same care as anyone else. And if there's something worrying you or troubling you and you're not sure, check it out. So that's just one thing I'd add. We'll also try and post on PoCoG any recommended resources or guidance for people. So over the next few days, we'll post those. So if our panel members have anything they think would be particularly useful to put on our website for people, we'll do that. But also post any resources that we're aware of. And please reach out if there's anything that you feel you want to discuss, or you want to connect with people within the PoCoG network, or we can help in any way. We're available and happy to be contacted. So thanks everyone for joining and come up. Particularly thank our panelists. It's really been a terrific discussion, and I hope it's been enjoyable for the rest of the people involved, and challenging and reflecting what's been a very complex year. And let's hope, I think we said last year, let's hope for a better 2021. I think this year we're saying let's hope for a better 2022. It's looking more optimistic, but and I guess hope and optimism is what gets us through these things, and we need to keep hold of that. But particular thanks to Maria. It's been really important for us, I think, to get that international perspective and to hear about those experiences. And it confronts us with the reality of COVID for so many people across the globe. So, and for our clinician colleagues. And again, thank you for sharing those experiences. And thank you, Jemma, and thank you, Laura. And thank you everyone who's participated. And have a great Friday night and a great weekend. Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you. Bye-bye.
Bye.
Bye.
Thank you.
everyone jumped off. You there, Laura?
Yeah, I'm here.
Oh, okay.
I think it's just us and maybe Maria's just gone. Yeah. All right. That was what? Good, wasn't it?
Yeah.
Yeah.
I thought it was. I thought it was lovely. I thought it was really, really informative, and I think it was quite raw, but I
Yeah.
I think it was